I start with this Renoir to also remind you that, certainly as an internal medicine doctor that is very pro-bariatric surgery, what we tell our patients is not that bariatric surgery is going to make them thin, but I want to take patients such as this with increased visceral adiposity, with increased visceral adiposity, diabetes, and maybe a sedentary lifestyle because of their functional inability, and I want to turn them into patients such as those in the background with a better quality of life. So really what it is, it's not about chasing kilograms, as Torsten puts it. It's about improving health. But how does it work? I'll leave my conflicts up a little bit longer this time. So what I first want to start off by saying is, what is it not? Right? And you will go to many bariatric surgery meetings and you will read many papers, and it starts off by classifying the operations as either restrictive or malabsorptive or the combination of it. Now, Lee Kaplan, a good friend of mine, refers to restriction as Santa Claus and malabsorption as the tooth fairy. So, your children believes in Santa Claus and the tooth fairy up to a certain point, and then they start questioning it. And I would like to ask you to start questioning those paradigms because maybe like the tooth fairy and Santa Claus, they don't exist. And I don't think malabsorption and restriction plays the role that we previously attributed to it. So I'm going to start off by saying I do not think surgery works through mechanical means. I think surgery works through physiological means. The anatomy changes are important to provoke the physiology, but just to remind you, this is a study where we studied obese patients, studied after an adjustable gastric band, Roux gastric bypass, and duodenal switch, and no doubt that if we look at 3-day fecal fat, which is the gold standard of determining a malabsorption, we see that the duodenal switch have that, but there's no difference between the bypass, the band, or obese patients. Now, we didn't study sleeves, but I would hesitate to say that sleeves have no fecal calorie malabsorption. And for anybody that's ever looked after a patient with a Roux gastric bypass or a sleeve gastrectomy, you will know that these patients often complain of constipation. Right, so I'm putting it to you, how on earth can you malabsorb calories and be constipated at the same time? So I would suggest that malabsorption does not play a role. The next is restriction. So this is work that comes out of the gas lab, Torsten and Lasse Vendricks authors on this. And this is where they placed a high pressure manometry in the standard gastric bypass that's done in Scandinavia. And they actually took the pressures in the esophagus, they took the pressures in the pouch, and they took the pressures in the alimentary limb. And what they showed, now if gastric bypass in this model worked through restriction, what you would say is this is a small gastric pouch and this is the stoma, so you would expect restriction to have a high pressure zone here. But in fact, they found a normal pressure in the esophagus, low pressure, the opposite, low pressure in the pouch, and the higher pressure zone was actually in the alimentary channel. Right? So it does not appear that the operation causes restriction at this level, but rather that the physiological responses because of the pressure effects that happens from food entering into the mid-gut over here may play a role. Now, of course, you cannot have a meeting in Gothenburg not mentioning the SOS study that's really taught us so much about surgery. But here I've just taken those with gastric banding and gastric bypass to show you that it's not only the weight loss that's impressive, it's the weight loss maintenance. And this is, of course, 10-year data. We now have the data up to 20 years showing the same. But that's human. So why do people lose weight? So this is a classical experiment done by Richard Atkinson, where he took, and this was done in the 1980s, where he did a bypass type procedure on a bunch of rats, sham bypass on another bunch of rats, and then he showed that the bypass rats ate 30% less than the sham bypass animals. But he then took the plasma from the bypass rats and injected it into healthy, unoperated recipients, and took the plasma from the sham bypass and injected it into healthy, unoperated recipients, and showed that the recipients of the bypass plasma was eating 1/3 less than the recipients of the sham bypass, suggesting that whatever was causing the reduction in food intake was carried in plasma. right? And that's really where we started to again think about what are the peripheral effects that are carried in plasma, such as the hormones, and how can that affect feeding after these operations. We did a gastric bypasses in rats, do the same bypass that Torsten would do in a human. We did those in rats, and what we're able to show is that the rats, exactly like the SOS study, lose weight and maintain their weight in the long term. These are sham-operated rats that gain weight throughout life. And when we actually measure their food intake, we can see that the bypass animals eat less. However, to make a group that is in the black solid circles here of animals that lose weight and maintain the same weight loss as the bypass, we had a sham-operated group that we underfed. So this is a very strict diet group that we put up here, and we get the same weight loss. But you can see there's a difference in energy intake. So to get the same weight, we have to underfeed the bypass, underfeed the sham-operated rats to get the same weight. And so where did that energy go if it's not coming out of the feces? Because we took the feces, blew it up in a bomb calorimeter, showed no difference in fecal calorie content, and the changes appears to be an energy expenditure. Now, we're not going to have time to go into that today, but I want to stress the point that most patients who come after these operations, adolescents, adults, what they will come back and tell you, as we've done in this prospective study, if we ask people how hungry are you before the operation, they feel quite hungry after a small meal, but their hunger remains suppressed after, at 1, 3, and 6 months. How full do they feel? Their fullness is low before the operation, but after the operation, the fullness is increased. And that's why they lose weight. They lose weight because they feel less hungry and they feel more full. And if you're less hungry and you're more full, it's quite easy to stick to behaviors of eating less food because, you know, that's the physiological signal. So what are the drivers of that physiological signal? This is a study that we did with Samantha Schultz. And when we actually looked, it's a combination of things. It's not only one silver bullet, but it's PYY that's elevated, it's GLP-1 that's elevated, it's total bile acids that's elevated, and ghrelin is not changed as you would expect, you know, normally after weight loss. So actual fact, it's what surgery does is this perfect combination of physiology. It appears to, and that's why I earlier joked and said the surgeons found the answer without understanding the question, but it's true because what they found is this perfect combination of the gut hormones, the bile acids, and other factors in combination that is working so well. I'm going to focus just a little bit on the gut hormone side because it's illustrative. And I'm going to use PYY in this instance just because it's my favorite hormone. But I can put up GLP-1 or oxyntomodulin. All the hormones from the endocrine L cell behave in exactly the same way. So this is a cross-sectional study. And what we were able to do over here is to show in the purple, that's obese patients. And if you give them a small meal, 400 calories, they don't have much of a response. Remember the previous lecture when I showed they have a functional deficiency. Here in the white line, we have the patients who actually are normal weight. And you can see they are having a little bit of a response, but the obese patients are functional deficient. In the white line over here, we actually have patients with gastric banding. They have lost 25% of their weight. But despite them losing all their weight, they don't recover their gut hormone profile. So weight loss does not allow you to recover normal gut hormone function. But if you look at the patients with gastric bypass, they have this early and exaggerated response that we see over there. Now, this is data from Torsten's lab, and Marlon Velling, that's in the audience, actually collected these patients as part of a PhD thesis. And here she found patients that lost 40% of their body weight after a gastric bypass, and they do exactly the same operation, but some patients actually only lose 20% of their body weight. And when we measure their gut hormone responses, we see there is an association, and here I choose to show you GLP-1, the same is true for PYY. Those that had lost the most weight was associated with the most gut hormone responses, and those that lost the least weight was associated with a lower gut hormone response. But this is just association. To really convince you of causation, what we have to do is I have to take the high gut hormones and suppress it, and then see what happens. Because I've already shown you the experiment, you'll remember earlier, when we actually took patients and we injected them with PYY or GLP-1 and showed that if we inject them, they eat less food. So now I'm going to try and show you that if I take this high hormones and I suppress it, what happens. And that's exactly what we tried to do with the octreotide experiment. Now, octreotide or somatostatin is effectively endocrine GIF. It blocks everything. You know, it's not specific for PYY or GLP-1. It blocks all the hormonal effects from the gut. So insulin, it blocks glucagon, it blocks GLP-1, PYY, oxyntomodulin. So what we had is a randomized double-blind controlled study, patients with gastric banding, where I already told you gut hormones are not in play. And when we give them saline or octreotide and we ask them to eat an ad libitum meal, they eat about 400 calories. In the bypass patients, we did the same study, and on the saline day, they ate about 400 calories. But on the day when they had octreotide, they almost doubled their food intake. Right? So now what we've done is we've blocked the gut hormones that were supposed to be high, we've taken them away, and suddenly the patients more than double their food intake. And what is intriguing is we have repeated this experiment recently in patients who had cancer surgery, who had cancer upper GI surgery, who had a typical Roux-en-Y construction, and we see exactly the same physiology. So if we block the gut hormones in people with cancer surgery, with a Roux-en-Y construction, or even with an Ivor-Lewis type procedure that's maybe more akin to the sleeve gastrectomy, we see this increase in food intake. So it appears that the gut hormones play a role, but here's the caveat. It's not the only factor, because remember, these patients still had body mass indexes of 35, and we're offering them ad libitum food, eat as much as you want, and they only choose to eat 700 calories. So if you offered an obese person with a BMI of 35 an ad libitum meal, they may eat 2,500 calories. So although the gut hormones are important, they are not the only factors that are important when it comes to the control of food intake. Just to convince you further, we did exactly the same experiment in rats and showed exactly the same increase in food intake with octreotide as such. So this is data from Anna Lorenius that's in the audience, and she did this as part of her PhD together with Torsten, following patients prospectively at 6 weeks, 1 year, 2 years, and show that they lose their weight and maintain their weight loss. Now, you that work in clinic will be very aware of this. So at about 1 or 2 years, the patients start ringing you up, or they come to clinic and they say, "Doctor, this operation's not working anymore. Because now I'm eating just as much as I ate before the operation. I have done so many diets in my life. I know that when it's failing, and what's happening now is, I'm eating the same amount of food as before." And then you ask them, "But what's happening with your weight?" And they say, no, my weight is fine, maintaining my weight loss, but I'm eating all this food. And of course, Anna showed in this paper that, of course, the patients are usually right. Because when we actually measured the amount of food that they ate in a day, you can see before the operation they ate about 3 kilograms. That's significant. So now we're just taking the food, putting it on a plate and weighing it. And you can see it reduces after the operation, but then at 1 and 2 years, it's up to 2.4 and 2.6 kilograms. So the patients are eating more food, and they're eating vast amounts of food, but how is it possible that they're maintaining their weight? And it's usually when the husband or the wife comes in with the patient and says, "Doctor, what did you do with my husband? This guy has never eaten a carrot before in his life, and now we go to a restaurant and he goes to the salad bar. You've changed my husband, in the hospital." And we refer to this as the "I don't enjoy burgers anymore" syndrome. And it's particularly interesting, to follow this in adolescents, because they are so much more adaptive. So, and they're also a little bit more expressive, as Billy has indicated. So we hear exactly the same when we study the adolescents. So if I can try and break that down for you, if we're going to talk about taste, I would like you to think of it in 3 domains. We talk about the sensory domain, the reward domain, and the physiological domain. So to give you examples, the sensory domain is, if I give you coffee and I put sugar inside your coffee, can you tell me, is there sugar in, yes or no? Okay. The reward domain is, do you like sugary coffee? Right? And the physiological domain is, if I give you sugary coffee, do you have a cephalic insulin release, or do you have salivation? So we'll try and break this down and look at each of these components within surgery. But I also want to introduce you to another term, and it was actually in discussion with Marlon at Kalandiska that this really came up, and we really started to understand it. This was a year ago, when we met here in Gothenburg with some other investigators. And this is the concept, the difference between aversion and avoidance. So, I take you back to, those heydays of you being 16 or 17 and you discovering alcohol for the first time. And, that first alcoholic drink that you got completely plastered on, be that tequila or whatever it was, for several years after that, you were not able to take the smell of it or the taste of it, right? That's typical aversion. So that's a new stimulus that you've been stimulated to, and, just the smell and the taste of it is completely off-putting, right? That's aversion. Avoidance, however, a conditioned avoidance behavior is more akin to, I like to drink wine. And I can probably drink a whole bottle of wine, at a good dinner. And, but then I know I need to stop. Because if I drink more than one bottle of wine, it would not go well with me the next day. But if I stop after one bottle, I can have another bottle the next day if I choose to have that. So that is avoidance behavior. So I know when to stop as such. So I'm going to just illustrate these two things. So we have used our rats again, and we can give them high-fat food, low-fat food, or high-fat food with Bisto. Billy and Andy will know that this is a contribution from the UK to world cuisine. This is a sort of a gravy that has a sort of a salty taste, and we can put that on to mask the taste of the high-fat food. And then we can ask the rats, eat whatever you want. And then we can put the rats that were destined pre-operatively to become shams or bypasses. You can see they eat the high-fat food either with or without Bisto. They will taste the low-fat food and probably spit it out. And then after the surgery, once we've done the sham or the bypass, the sham operated will eat the same food that they did before, but look at the bypasses. They eat less food in total. They still eat mostly high-fat food, but now there's a 4-fold increase in low-fat chow. Okay? So you try and make a rat eat low-fat chow in preference when it actually has high-fat chow available to it. So the rat is basically eating the high-fat chow, stopping, saying, I'm still a little bit hungry, and what's around, I will eat a little bit of low-fat chow because that allows me to feel full. So we tested this in rats that were either pre-exposed to high-fat chow or not exposed to high-fat chow. So we took rats, we either gave them high-fat chow here, and then we operated on them, and then we actually waited until 26 days after the operation. They were just getting normal chow then, and then we gave them the option of having a high-fat or normal chow. And you can see the first day after the operation, first day when we give them the choice rather, they go for the high-fat chow and they dramatically reduce their low-fat chow. And then the next day, it's like, well, I eat actually a little bit less of the high fat, and then a little bit less of it, and then it stabilizes. And then you can actually see how they increase their normal chow again, right? Now, if we actually have rats that's never seen high-fat chow in their lives before, and we do a gastric bypass, and we offer them the high-fat or normal chow and high-fat chow here, you can see that they go for the high-fat chow, not so much, but they reduce their low-fat chow, but the next day they almost don't touch the high-fat chow again. So here's a good illustration of conditioned taste aversion. That's a new stimulus that you've not been exposed to, that you don't like, and you stop taking that. And here's a good example of conditioned taste avoidance, where you actually know that high-fat chow is nice, but now what you do is you eat less of it. Don't go to zero, but you eat much less of it, but you actually prefer to eat the low-fat chow. And that is a physiological shift that is very intriguing. There is evidence from conditioned taste aversion in the rats, and this is work that we did with Thomas Lutz, and to show this is a classical conditioned taste aversion to fat, and it appears in our hands, and again this is an observation that Torsten made earlier, in humans, that it's actually fat, much more than sugar, that is driving this behavior as such. There's no doubt that there's post-ingestive consequences after bariatric surgery. This is work from Samantha in bypass using the 6-stat score, and this is work with Galia Abdeen in adolescents with vertical sleeve gastrectomies. in Saudi Arabia, where you can also see an increase in nausea in the sleeve patient. So both the bypass and the sleeve have post-ingestive consequences. Intralipid is a liquid that we, of course, use for parental nutrition, but we can either give it to rats as a liquid, so that's water or intralipid, and we shift the bottles around and we change the concentrations. And what you can see, what rats do, as you increase the concentrations of intralipid, is the sham-operated animals will eat vast amounts, and they will only drink intralipid. It's like a milkshake to them. They really love that. Where the bypass animals will drink some intralipid, about 18 milliliters, but won't increase it as the concentrations go up. And if we express that as a percentage to water rather, you can see that the sham animals only drink the intralipid, they don't drink the water, where the bypass animals drink intralipid and water about 50-50. So the animals are choosing to avoid drinking high concentrations of the intralipid. It becomes confusing a little bit when we do a brief access test. The brief access test is a test where we very briefly exposes a rat to a small amount of liquid. In this case, we use sucrose. So we give them a very small amount of sucrose, and then we see how often they go to the spout and how often they lick. And we give it to them for 10 seconds, and we take it away. Then we give it again for 10 seconds, we take it away. And we can actually measure how many times they go up. And what we actually see, and this was completely contrary to what we predicted. We predicted that the rats won't go for the sucrose so much. But actually what we see is this is before surgery. The shams and the bypasses did the same number of trials. After surgery, the bypass animals actually went more frequently to the spout. So if you actually give them a small amount of sucrose, they liked it. It appeared they at least approached the spout more frequently. And that sort of, again, suddenly starts making sense when you listen to patients in clinic when they say to you, you know what, after the bypass, I still like chocolate, but now instead of eating a whole bar, opening it up and eating the entire thing, I now only have 2 or 3 blocks. And actually, I actually buy better quality food now for the first time, so because I like it more as such. And certainly the rats seem to behave in a similar way. Why is that? Because we're interested in the reward centers of the brain. So when we do functional MRI, we can actually look at food appeal, and you can see that the bypasses in the black over here have less appeal for the high-calorie foods, but no difference for the low-calorie foods. And specifically, chocolate, other sweets, and non-sweets are reduced in the bypass in comparison to patients with banding or BMI match controls. And when we actually look inside the brain with functional MRI, we can see that it's the brain centers that's involved in reward that are altered. In fact, what's happening is the brain centers are down-regulated after gastric bypass. Again, consistent with what we hear in clinic, because patients, after the surgery will say, now I can walk past the cupboard, full of cookies. I'm just not bothered with the food anymore. And I think I said earlier today, people say, I wake up in the morning and I can think of other things except food. I'm just not concentrating and preoccupied with food. And that's consistent with when we look at the reward centers in the brain as such. But as I suggested to you, functional MRI is sort of interpretation of shadows with complex statistics. But if we actually want to measure what's happening in a behavior, so what does it mean, these changes in the brain? And so here's a classical test called a progressive ratio task. And this is used quite extensively in addictive behavior. So what we do here is we measure how hard somebody would work for a reward. So what we do is we actually offer patients M&M. You can see those little M&Ms over there. And, once you start eating one, you have to continue to eat them because they're very, very moorish. But now we say to the patient, what you have to do is you have to press a button. So if you want one M&M, you have to press the button 10 times. If you want the next M&M, you have to press it 20 times, and then 40, and then 80, and then 160, and then 320, and then 640. And at some point, pressing the button becomes more work than actually getting the M&M. And we call that the break point. Right? So here's control subjects that we tested 8 weeks apart, and you can see people press the button the same number of times before and 8 weeks after. They like M&Ms the same. Right? Now, if we actually tested patients with gastric bypass, you can see that they press the button half the number of times 8 weeks after surgery. So the amount of work that the patient after a gastric bypass will do to get a sweet and fat reward has reduced by 50%. Right? And that is consistent with what I've just shown you, the functional MRI has shown. So the reward centers are downregulated. The amount of work that you will do for the reward is downregulated as such. I was very surprised at this, but the data is the data. And it appeared that the decrease in breakpoint correlated with a decrease in BMI. So it means that the patients that had the biggest shift in reward, downregulation, were also the ones that lost the most weight. And we've actually repeated this study now in patients with sleeve gastrectomy, in adolescents with sleeve gastrectomy in Riyadh with Galia Abdeen, and we found exactly the same responses as we did with the gastric bypass in adults. We find the same with adolescents with vertical sleeve gastrectomy. This is again the appetitive behavior, and this is again exactly what I've just said to you, that the sleeve gastrectomies reduce the break point for M&Ms as such. Right. So just wrapping it up. You remember I showed you that if I give octreotide, I can make people eat more food. So what we wanted to do is, if we give octreotide, what happens to the brain? And when we did that, you can actually see that when we give Roux-en-Y saline and we give Roux-en-Y and octreotide, we actually increase the reward centers. So remember the story, obesity, high reward centers. Now, if we do bypass, we reduce the reward centers. If we give octreotide, we increase it back again. So it almost like we can switch the bypass on and off to some extent by using octreotide. And again, if we use the test of pressing the button, we can actually take patients who are stable after gastric bypass 2 years, and when we give them octreotide, we increase the number of times they press the button. So we are seeing the changes in food intake, we're seeing the changes in functional MRI, and we're seeing the changes in behavior, suggesting to you again that the physiology of these operations is really the way it works. So I'm going to summarize and say, if you are lean, the more food you eat, the fuller you will feel, the more satiety you will have. If you're obese, that curve is shifted to the right, so you have to eat more food to get to the same level of satiety. But if you have an operation such as a bypass or a sleeve, it's shifted to the left, and therefore fewer calories will allow you to reach the same level of satiety. And that is why they lose weight, because you actually have a reduction. So just to thank the people I work with, again, specifically in Gothenburg, thank you very much.